Clinicians recognize just symptoms of systemic sclerosis and then also the initial evaluation. We will need another 2 hours to go over treatment, so I'm not going to focus on that as much. These are kind of the learning objectives that are set around, just as I mentioned, the clinical clues, features, mainly just showing you lots of pictures. So hopefully you will identify the cutaneous musculoskeletal symptoms to say, hey, this patient might have something going on. Maybe we should send them to rheumatology. That's my main goal today, and for you to understand the impact and the seriousness of this condition. But it crosses many disciplines, so that's why I think it's relevant for Peds Grand Rounds. So there's some cardiologists, GI folks, et cetera, in the room. I think it'd be helpful to know about this condition and how to initially investigate and manage these patients. I'm not going to talk about localized scleroderma. That is with Grand Rounds a couple years back, and that's what Elaine was mentioning. I have a craniofacial scleroderma center as well, like dedicated to that. But today we're going to talk about systemic sclerosis. So that is basically the skin thickening that occurs on cutaneous, so the skin kind of all over the body, but then also in the internal organs, you get a mix of inflammation and fibrosis, where you have interstitial lung disease, you can have cardiac disease, renal disease, et cetera. So it's definitely a multi-system condition. These are pictures of my actual patients. I have permission from everyone, but you guys can see like the thin, veiny skin. This is a 13-year-old. She should not have skin that looks like almost aged because of the atrophy of the subcutis. This is a picture of the interstitial lung disease and the chest CT. This is not good. You don't want inflammation and fibrosis in your lungs. You can't exchange oxygen and you have trouble doing day-to-day life. Another picture of the kind of like the thin lips and the showing, I'm trying to find the mouse. Yep. No? Okay. We'll figure it out. So her thin lips, and you can kind of see her teeth, and her face is pulled back as well. There's calcinosis on the very far side. And then there's pictures of Raynaud's, of fingers turning colors in the cold. The chest is like a shield chest. That's skin thickness 3. Like if you would touch that young man's chest, it'd feel like hard rock. And then those are kind of the claw hands you guys might learn in medical school from adult scleroderma, that they kind of get the joint contractures after the skin and the tendon and joint involvement. The esophagus is showing that the esophagus is very dilated, dysfunctional, and can have strictures and dilatation, and it just doesn't like move the food through correctly. So a lot of the patients will just have kind of silent aspiration. They're just not moving, things through their GI system correctly, and they'll accidentally kind of aspirate, and then that propagates their interstitial lung disease as well. The last one pictures, we'll go over that when we go to the overall health, but these kids start falling off the growth curve, and sometimes that's their only initial symptom, and then the Raynaud's and other things start up. So do pay attention to the growth curves. That's sometimes the poor nutrition and just the unwellness of the patients that starts this condition. I am not going to go over the pathophysiology. This is my literal one slide. I just, in all fairness, that belongs to like they maybe research Grand Rounds, and I have do skin biopsies and single cell seq and all that fun stuff. But I feel like that's not what this talk is about. This is just more showing the 3 pillars of systemic scleroderma that propagates the disease. It's inflammation that we see in all of our autoimmune diseases. But what makes this different is it has a fibrosis. So it kind of inflames the fibroblasts to lay down collagen. So you get thick skin and actually fibrosis in the lungs, et cetera. We typically don't see that in juvenile arthritis or juvenile systemic lupus, et cetera. So that's what makes it kind of different. And then there's a vasculopathy. So something's wrong with the vessels. If you've seen these patients, you've seen they have Raynaud's, their fingers turn colors, they get digital ulcers on their tips of their fingers. That's because the vessels kind of taper off towards the tail ends of the fingers, and then you're just like getting avascular areas. So you get these little necrotic ulcers. So it's a mix of these 3 things that kind of propagate and then drive disease. And on the research end, I'm working on kind of clarifying that a little bit further. So what we're here, though, is on the clinical end is how to kind of at least have a spider sense about something going on, and then how to kind of further investigate. So it's a rare condition. This is kind of older incidence and prevalence. I feel it's more. In the last 24 hours, I've gotten 4 consults, 2 from California, 1 from Texas, another one from Midwest. But I feel like it's out there. It just was unrecognized in children. But it does seem to be slightly more female than male. It's definitely not as strong as adult systemic scleroderma. And like that's usually women in their 40s is the average, and that onset is closer to kind of like a 7-to-1 female to male ratio, where this is more of like 2.1 to a one-ish ratio. In general, in kids, when it does happen, it's usually around 8 years old. That's the average age of onset, and then it does take a good year and a half or so to get the final diagnosis, just because it is rare. So just any pediatric rheumatological condition, please remember, this is really a clinical diagnosis. It's really that great history and physical exam and pattern of symptoms that really help us diagnose things. The labs are wonderful, but they're supportive. Like, please don't randomly order a centromere. Like, let the clinician do that, because there's some false positives and things like that kind of lead people astray. But this young girl is around 8 years old. Her onset, you can see she has a thin lip. She had a little bit of skin thickness on her face and her arms and hands. She has these tapered fingers, and then she has digital ulcers, if that's portraying okay, on the tips of her fingers. She really didn't complain at all. She's a farm kid. She's out there milking the cows and all that stuff, but they're like, "Ooh, her fingertips hurt," and it's like, "Oh, well, she has scleroderma." So this is just an example of a patient and their onset. So as I mentioned, this can hit any organ system in kiddos, just like in adults. Why I highlighted the orange is those are ones sometimes that you have to think a little bit more about. Kids are not very forthcoming. If they're starting to have shortness of breath from interstitial lung disease, they're just going to kind of stop playing their sport. So they might not play basketball in the team. They might just shoot hoops in the backyard. And then you're like, oh, it's not until you really push them about specific questions of shortness of breath that they're like, oh yeah, maybe it is a little harder to get up those steps and I get winded, but they're not going to offer it to you. So that's why I kind of highlight these things that you really need to kind of dig in and ask. They really just don't complain. So, you guys learn about adult systemic scleroderma maybe one day in medical school. I mean, for one day. So, a lot of the times the question is, okay, well, we got a snapshot of that. Are kids similar to adults? And big picture, yes, it affects us similar organ systems, but in a nuanced way. Like the frequency of the affected organ system is a little bit different, and how these things kind of show up and how they kind of populate in certain groups of patients is a little bit different. So we have a couple registries. So we have, as Elaine mentioned, the National Registry of Childhood Onset Scleroderma here. So we were kind of building that up over time. I have 150 patients, which doesn't sound like a lot, but that's actually is for a rare disease. And then there's the CARA, that's Childhood Arthritis and Rheumatology Research Alliance, which I help orchestrate as well. And then there's an international inceptions cohort that has about 300 kiddos in it. So we kind of followed these patients longitudinally, gather data, and just compare them to the adults. So this is a little deep. So we're not going to dive in too much here. But just so you guys are aware, there's 3 main types of juvenile systemic sclerosis. And the 2 main ones are basically of how much the skin is involved. So diffuse cutaneous is kind of that. So it starts on the fingertips and toes and kind of works centrally. So diffuse is when it goes beyond the elbow and the knee, and it goes kind of central. Whereas limited, it usually stops at the knee or the elbow. So that's kind of the diffuse versus limited. And why it's kind of interesting is because at least in adults, we're still pinning that out now that we have larger number in kids, but in adults, the pattern of the skin involvement does reflect the internal organ involvement. So the diffuse cutaneous kiddos or adults are more likely to have that interstitial lung disease, whereas the limited cutaneous are more likely to have this smoldering low-grade GI disease that eventually takes over and is quite severe, and later pulmonary arterial hypertension. So that's how those kind of help as far as categorizing. And then also they're associated with different autoimmune antibodies. Especially in adults. In kids, I would say the SCL70 or the topoisomerase, that does go along with more kids that have diffuse cutaneous. We don't have that limited cutaneous as often. That's the CREST syndrome, if they still teach that in medical school, the calcinosis, Raynaud's, esophageal dysmotility, the sclerodactyly and telangiectasias. So that happens in kids, but less often, and the centromere is pretty rare. And then the third one, though, that I want to highlight that some of the adults actually look over because I don't know if they don't know what to do with it or they just don't see it as often, but we actually see way more overlap. So we see kids that have features of juvenile dermatomyositis or lupus, et cetera, but usually dermatomyositis. So the heliotrope rash, the Gottron's papules, those kind of changes on the extensor surfaces, muscle myopathy, myositis. So we see those more often. This is 30%, but actually now that we're kind of digging through cohorts, it's going to be closer to like 35, maybe even 40% as the limited go down, the overlaps are coming up. These patients have a specific antibody PMSEL, that means polymyositis scleroderma. So actually you fit all the features for scleroderma, but you get a bonus where you also fit the dermatomyositis features as well. So these patients have more myositis, arthralgia, et cetera. They're important to know about because with the peripheral myositis, you can potentially get cardiac myositis as well. So these patients, we do worry about if your heart is involved and you get inflammation and then fibrosis, the kind of your EKG and things get abnormal, you can get arrhythmias because you're not kind of conducting through the heart normally. So those patients, that's what we kind of flag them. The antibody panel that we like, if you guys are here in us with us in clinic and et cetera, that we like to validate any kind of, sometimes the ANA is done as like a reflex and you get this antibody and you're like, okay, is this something or nothing, a centromere? We really do prefer like to validate it, sending it out to the Oklahoma Medical Research Facility. They have a certain scleroderma panel and they do this by immunodiffusion, et cetera. So it's kind of like the old school way instead of the newer like Luminex way. So we kind of like the old school. So that's what I'm just going to mention that. Again, and this is just showing what I was mentioning, but in a different fashion, is that skin thickness as that diffuse versus limited kind of does go along with time. This is years where the patients with the diffuse cutaneous, that first 2 years of disease, that's when they have the highest risk of having the myocardial involvement, ILD, et cetera. Whereas a limited cutaneous kind of like have that smoldering disease, but then it gets bad later, like pulmonary hypertension and GI disease. And the overlap have like a mix of these features. This is an older study done here at Pittsburgh. I think Tash Alker-Chowdhury was part of this, but I think it was before. Before I was even a fellow is when it got put together. But it was basically comparing children, young adults, so adults in their 20s, 30s, and then the typical adult onset, so adults in their 40s, et cetera. And it showed that overall they're pretty similar as far as like the involvement of skin, vasculars, Raynaud's and digital ulcers, joint tendon involvement, like joint contractures, GI involvement, and lung involvement. What differed, though, is the skeletal involvement was 30% in kids versus 15% in adults. That makes sense. That's kind of what I mentioned, that we have more overlap. So that kind of carries forward because this data was pulled from like 1980, 1990, et cetera. So this is actually pulling forward to the 2020s. It's still accurate. And those ones have more of that antibody I was mentioning. Whereas the kidney disease, which is the renal crisis, we'll talk about just for a minute, because honestly, we don't see any of the kids in my cohort or the international cohort, but I know one-off that happens. But that's basically like an urgent hypertensive crisis. You can treat with ACE inhibitors, but that's associated with the RNA Pol-3 antibody that we really don't see that often in kids, and we don't see that manifestation. So even though this was years back when this data was pulled in the 80s, et cetera, it does still ring true to the current cohort. So we just have a little more musculoskeletal involvement. And then this is just background, like how I got to know what I know. Is one of my mentors, Dr. Tom Metzger, is a world-renowned scleroderma expert. And when I was a fellow, he was here. And Pittsburgh is actually one of the first scleroderma centers, like internationally. They have, I think Robin has about like 8,000 patients or so. It's like one of the largest centers, and it started back in 1967. So Tom Metzger's mentor is Rodnan. So the modified Rodnan skin score, if you guys are ever in clinic or you hear me talk about it, that was developed by him. So basically, like the start of epidemiology studies and like more legit clinical studies in the US was started by Tom's mentor, and then Dr. Metzger was my mentor. So it was kind of cool going into clinic and seeing these patients with him. So now in my mind, I have a conceptualization of what systemic scleroderma can look like in adults, because in kids, as all you guys know, in different specialties, like it's usually not as robust, right? There's like these subtle clues that something might be going on. And this is true for all of our diseases, whether it's lupus or dermatomyositis, like usually it's a little more subtle. And then, so kind of learning the more severe phenotypes and then bringing that home and figuring that out, what that looks like in kids, I think has really helped. And then the multidisciplinary team, I'll come to a slide in that in a minute, but I definitely have my crew here that helps from all the different organ manifestations, and I'll show a picture and shout out. But you can't work in an island, right? You need GI to help, cardiology, pulmonology, et cetera. So we have that here at Children's Hospital of Pittsburgh, which is awesome. So I definitely appreciate all that help that I get from everyone. So this is just hey, you walk in a room, pay attention, right? Actually look at the weight, look at the growth curve. The BMI, when we have these international consensus meetings, it does seem to be something that is a trigger to A, make you think about juvenile scleroderma, but B, it actually is something that changes when they have therapy and they're getting better. So immunosuppressive therapy, their skin's getting better, globally they're getting better, the GI tract will improve as well, and they'll start to kind of like absorb nutrients and eat better. So we do see that kind of improving once we treat, but these are just signs that this patient's not doing well. So there's a more average patient on the top and then a more severe patient that's like literally falling off the growth curve, just to show you that. Pay attention to the vital signs. Heart rate, blood pressure. Our kid's actually going to have the lower heart rate and blood pressure. If you have a high blood pressure in a system and someone you suspect has systemic scleroderma, that's bad. That might be something else is going on, renal crisis, et cetera. And then if you can try pulse ox, the little trick, don't get freaked out. If you get a pulse ox and it's like 86, 90%, that's usually because they have Raynaud's. Really try to find that ear probe or the forehead probe pulse ox, not the finger probe one. And then I actually make them walk around in my clinic because I've been fooled a lot. I've just been fooled in general because in general rheumatology clinic, you guys might see us do this. For kids, even we're suspecting juvenile arthritis, we're like, run around the room, race down the hall. It just gives you a better idea of like what their function is. A kid sitting on the table may look okay. And I've had patients that are seeing like high-level other pediatric specialists across the nation, and they kind of miss things because they're just sitting there on the exam table, right? It's totally different if you make someone walk around the circle. I'll show you a slide in a minute, but I've definitely caught some patients that they knew that the clinician knew they had scleroderma, but didn't know the degree, of maybe their desaturation or potentially if they had cardiac disease, et cetera, because they're like okay when they're sitting there. So this is a one patient example. So this is a classic early scleroderma or overlap patient. She actually has a little bit of Gottron's sign there, periungual erythema. You can see this is sclerodactyly. These are swollen fingers. And this is after I made her walk around a circle twice, and she's totally blue. And she's tachypnic and a little bit tachycardic. Unfortunately, I only had a finger probe, so it was 86 degrees. So that's not like her true sat, but she did get very tachypnic. And I was like, something's going on. She actually didn't have interstitial lung disease. She had myositis. Her CPK was elevated. And this is after rituximab, IV steroids, CellCept. She was on all the medicines. So we pushed a little bit. She didn't even complain of having any skipped beats, no heart, chest pain, nothing. But I was like, something's not right. So she got a cardiac MRI. And she actually had both active inflammation and also fibrosis on her cardiac MRI. So that's just kind of lesson learned to like push them, walk them around. They're not going to complain. She really just stopped. I guess she started using the elevator at school instead of the stairs, but she didn't say she was getting short of breath. She's like, oh, I'm just tired is what she'd tell people. So you just have to really push them. I'm not going to go over this in detail in the essence of time, but just, any rheumatology patient, you want to do the full head to toe exam. I just highlight things that in kind of the blue that were deemed kind of 12-month outcome measures if we have a clinical trial, but all of these things are important. And we'll go over them actually when we get into the different organ manifestations. So skin, what we see in these patients is kind of what I showed you in the one slide in the top. That's kind of the early edematous phase where you have like that sclerodactyly or that kind of swelling. You can get the swelling in the feet as well. And it almost looks like cankles, like generalized edema. But with that initial swelling, you start to get the inflammatory infiltrate I'm showing perivascularly and deep in the dermis, but then you actually start getting the collagen to start to be abnormal and lay down a little bit funny. So it's just the very beginning. It might not feel thick at that time, but within a few months, usually it starts feeling thick. And that's the collagen laying down more throughout the skin and deep dermis, et cetera. And then the biopsy on the lower part is the late changes. That's when really that collagen is dense. And then that's when you get like that claw hand when you can't move all the way down. And that's a young girl. She was about 8 years old in that picture. So you should be able to get your finger down to your palm if you guys do that, like your distal palmar crease. But she could only get to like that. So like 3 centimeters, she couldn't grab. So that affects your grip, right? Grabbing things, kind of putting on clothes, that becomes a problem. So you guys don't need to know the details of this, but just so you know, like this is our anchor for a lot of clinical assessment, just to say, hey, how bad is the patient? How severe? In adults, it's actually the skin score. So you're basically scoring all the parts of the body, and you're just doing mild, moderate, severe, or absent degree of skin thickness. So you're kind of pinching the skin and seeing if it folds or not. The score in adults correlates to disease severity, activity, and mortality. There's like a skin thickness progression rate that they calculate. In kids, I definitely do see it associated with more severe disease. Like kids that have 20 or higher are usually kind of something else is going on. Either they have bad skin, musculoskeletal, sometimes they're refractory to medications, or interstitial lung disease. So it is helpful to get that skin score and kind of do that routinely. And it does respond to therapy in some patients. So it is also a good marker for clinical trials. These are more skin changes that we see. Again, I'm just showing you different pigmented patients. So patients with darker skin, with sclerodactyly, and then they actually get what we call salt and pepper hypo and hyperpigmentation. That is not vitiligo. It's been misdiagnosed in a bunch of my patients with darker skin as vitiligo. It's just like on the extensor surface, you just get a little more wear and tear, and somehow that's like changing the inflammation in the melanocytes, and you get low pigment in those areas. You can get the opposite. You can get hyperpigment. The young lady on the far right, that's actually like thick, scaly, darker than her normal skin, and that's hyperpigmented. And this is me asking her to extend and flex. She's the one that I had a video that's quite severe, and she's like awesome after stem cell, but we'll get there sometime. And then these are just subtle telangiectasias in kids. Like sometimes they're not as striking as in adults. Like the young girl, it's like on her nose and kind of her eyelids and her cheeks. And then this is kind of more obvious telangiectasias on the young lady in the middle who's trying to open her mouth, and she's only opening to like 2.5 centimeters. You should open to like 5.5 or so centimeters. And that's hyper and hypopigmented on the abdomen that you can see. So these are just different pictures, just so that you guys can help recognize some of these things. So calcinosis happens, I would say probably like 20% or 30% of the patients. It's also seen in dermatomyositis. That's the other one that we usually see it in. It might be confusing. That's someone's knee flexed. If you're like, what the heck is that upper picture? So that's calcinosis likes to happen on the extensor surface. We think it's like a lot of wear and tear that somehow incites this inflammatory and then kind of calcinotic reaction. You can get it on the tips of the fingers as well with the digital ulcers. So that's just kind of showing you some pictures. I showed you the picture of all the atrophy as well. Like patients can have thin skin globally. They just can be like very veiny. They lost the subcutis. And then you can get ulcerations that aren't directly the digital tip ulcers, but are kind of more on the elbows, the knuckles, things like that. And that's just kind of a little bit of the vasculopathy as well. I wanted to show you what in the adults, like what they see. This is one of my colleagues, Robin Domsick, her patient, where she actually had pediatric onset, but kind of like later pediatric, like 16 or so. Just so you guys can see what she looks like in her 30s. So this is 20 years old, so 4 years after that. Her 16, you don't really see it too much. She might have a little bit of tight, but you can't tell. But then 20, she's really lost a lot of that fat around her face, and her nose is very pinched. By 24, if you guys can see, she has like these big telangiectasias all on her upper arms, chest, some on her face, and then her fingers, she has auto amputation. Her second finger is actually kind of shorter than it should be. That's from Raynaud's and digital ulcers over and over again, causing like an auto amputation there. So you can see she looks much different than when she was 16. And that was just, several years later. And then at 32, and she had bad lung disease, et cetera, she's basically missing like all of the fat from her face. And she looks more of like the adult typical scleroderma facies. We'll have to see. I'm hoping that maybe this era, we might not see that as much, because in general, we are way more aggressive. Like all the kids that I see, they're basically on CellCept and some other biologic, usually like Actemra, which is IL-6 inhibitor, or rituximab, et cetera. Where when I trained with Dr. Metzger, which is not that long ago, how old am I? Oh, okay, maybe like 17 years ago. He actually, they wouldn't treat unless something happened. So they would treat if there was interstitial lung disease that was found by X-ray. This is before they did chest CTs routinely. So it's like late, right? So if they found ILD or some other complication, they would treat that, but they actually wouldn't necessarily treat the skin disease. And that mindset is completely flipped on its head. In the adult world now, they're treating with Cellcept and other things like more aggressively, even treating now the very early, they have a name for it, VIDOS. It's like very onset diffuse cutaneous scleroderma in adult world. So finally, like our kind of methodology has kind of got into the adults where they're treating a little more early. So I'm hoping we're not going to see this as much as what I'm getting at. But there's those severe patients that are going to do that. You know, this is a real life example of what happened in peds is this young girl down from Florida got referred to us, and like this is pictures from her mom's cell phone at my first visit with her. So that's her as like a 4-year-old little tiny peep, super cutie. And by 7, her dentist is like, I can't open her mouth. Like her mouth just really won't open. You know, her face was tight. I don't think anyone noticed that. And then 7 years later, you know, again, they didn't, I think people just didn't recognize, but by the time she's getting ready for her dance there, when she's 13, she has she has tight skin on her chest, her arms, her face, and her like, you know, she's a classic facies already, losing the subcutaneous tissues. And then she's had some joint contractures, et cetera. And then it was then where she started getting some evaluation, and she had florid interstitial lung disease. And I'll show you her CT next. So she came up to us for, you know, stem cell transplant evaluation. So when she saw us, she has a little cushingoid here, but she had some nail fold capillary changes, some mild skin changes still, but her lungs looked awful. So her pulmonary function test, her FVC, her forced vital capacity, 52%, total lung capacity, 65%. Her DLCO, so her diffusion capacity, 30%. That's not good at all. She's one of the ones that we made her walk around in clinic, and then she became tachypnic and everything, and she actually desats and needs oxygen when she exercised, but no one told her that. So she had pretty severe disease. So that's 7 degrees of progression, 7 years of progression. But I feel like there's just this large gap, right? That she really didn't show up to the rheumatologist down in Florida until some things progressed. And then, you know, by the time she saw, she had pretty established interstitial lung disease. The good news is this is her 2 years after her stem cell transplant. We were down at Florida at a patient care conference, and she's like doing great. You know, she still needs her oxygen when she walks around, but she is much more happy. Her skin looks wonderful. She's on an exercise bike, and she's like, I couldn't even do that before. She's now 4 years later is a latter picture. She's walking around campus at college, and she's doing a psych degree, and she's like very happy. So it was a life changer, you know, that we could offer her that therapy. And we're the only center here that does that in the nation. So that this is my slide that I said I was going to give a shout out to. And there's folks in the room today. I think I saw Kirsten and I saw Paulina. So it's a multidisciplinary group that we have here with rheum, GI, cardiology, pulm, BMT, PT, actually OT. There's some people missing on here, psychology, et cetera. So patients that have systemic scleroderma and they're moderate severe come to me, get some opinions, but in addition to that, you know, one of the things that we offer here was we have a protocol for autologous stem cell transplant. And it's been very successful. I mean, that patient was an example. The other one that I was going to show you the video was literally like in a hospital bed in her townhouse on the first floor, where her bedroom's actually upstairs. And she was 18, and at 16, she was like a star basketball player. When she came to us, like she was like this and couldn't even get out of bed. It took 3 adults to get her out of bed. And 3 months after the stem cell, she could like walk around and do a little turn. By 12 months, that last video I was going to show you, she's literally walking down the hall and like dancing and doing some like dance and jumping. And I was like, this is not possible. So it's a miracle for these patients. I mean, I think I'm blessed to be goodness, I'm just like blessed to be here with this great group of people and that we have these cellular therapies. I'm a rheumatologist. I walked in and I wasn't like, oh yeah, I'm going to do stem cell transplant, right? That's not where I came from. But working with Paul and the group and Paulina joined, I mean, it's just been awesome. So it's a great team. And if anyone else wants to join or has interest, especially with Biba leaving, so if there's any GI friends, just because they have these like certain, you know, issues that other people don't know. But when you work at it as a team, you kind of learn that, right? So that's why I just wanted to highlight that we've transplanted 9 patients so far. They're all doing phenomenal. One patient did relapse, but she said, I'd still do it again. I'd still go. So I had that like summer in Guatemala with my grandmom and kind of going around and just like being normal again, right? So it's definitely something that's kind of inspiring, and more people are coming, right, Paulina? A couple more lined up. So this is not important for you guys to pay attention to it, but it just shows the main features, and we use a criteria to say, hey, do you have scleroderma or not? But one of the things that has helped people is they realize this puffy fingers or sclerodactyly is part of the scleroderma diagnosis. Back in the day, you had to have skin thickening like beyond your wrist, basically, to say it's scleroderma. So kind of loosening that up, we're able to catch kids earlier. So then I'm working with colleagues across the world to kind of make that classification criteria a little more broad even for kids to pick that up sooner rather than later. These are vascular issues, as I kind of mentioned Raynaud's. Everybody has Raynaud's, 90% or so. But these are pictures. It can be one finger, all fingers, and then the nail fold capillaries are your clue to something might be wrong. These are clear as day, you know, from across the room. Those are dilated nail fold capillaries. The kind of the cuticle is kind of unhealthy, can be thickened or yellow, and then you get the distal ulcers on the tips of the fingers and around the edges of the fingers where you're not getting any vascular flow. And then this is the nail fold. If you guys been in room clinic, you've seen me use that dermatoscope and my colleagues. It's very helpful. And then Megan is doing a project for her fellowship project, and we're actually doing a video capillaroscopy on top of the dermatoscope. So we will learn more. They're seeing in adults, and we think in peds there might be a predictive value to like these different patterns. So that's why it's helpful. It's kind of your little gateway into the vessels. Myositis, like don't forget this, the kids just are doing less, so they're not moving as much. One of the patients was actually that we did the stem cell, who's now again at college running around doing fine. She was hospitalized for 2 years and just wasn't really moving that much, and no one just kind of put two and two together, but she had wicked myositis. This is her hip pelvic girdle MRI and then her shoulder MRI. So she had inflamed muscle disease throughout, and her antibody went along with that. U3RMP is his overlap one. So lots of things can happen, but this is not a typical, if you've seen our kids with juvenile arthritis, like a big swollen knee, this is not that. It's more of like this creaky kind of bound down kind of older feeling arthritis. We call it kind of like a tenosynovitis, but it's not super inflammatory. The other thing that's kind of interesting and in this disease only really is acroosteolysis. And sorry, this image didn't pop up too well, but with that Raynaud's and vasculopathy, the fingers, start resorbing and the bone's resorbing. So that's acroosteolysis. So we see that a lot in kids. I would say like 30% at least. And then, so this is just for, evaluation. We do a muscle test called CMAS. It's a childhood myositis assessment scale, but you learn a lot, not just from doing like can I push you down, but you actually make them lift their leg for 2 minutes. They get tired after a while. So then you kind of like have them do sit-ups or have them squat and get off the floor. You really if you just make them try to sit on the floor and get up, like a lot of them won't even do it because they can't, because they're going to fall from their contractures and their weakness. I showed you guys briefly the finger to palm. This is just a kind of measurement that we do. In the essence of time, I'm going to go over this a little faster. We talked about the oral aperture. So these are just kind of clues where things can happen. So the interstitial lung disease, I did want to talk about this. So please, if the rheumatologist is like, hey, we should get a CT scan to screen for interstitial lung disease. Like, let's do it. Before they were doing chest x-rays, that missed everybody. That's like not till way late. So we actually pulled that international cohort and looked. The pulmonary function tests are wonderful to follow up longitudinally. They're great to do in the beginning, but they're not diagnostic. They're not going to be diagnostic for ILD. You can have abnormal pulmonary function tests for muscle weakness, et cetera. And you can have normal pulmonary function tests and have ILD. So that's what we found is there's actually missing like almost 60% of the kids if you just relied on the FVC greater than 80%, right? Which is like going by the wayside in my mind. So getting that chest CT, we found 40% it occurred in kids, and now we're on par with the adults because that's what the adults see as well. And then for kids, a lot of times they won't have symptoms, but when they do, it might just be like a chronic cough, daytime cough, and then some shortness of breath with certain activities. They'll just kind of peel away from doing some of their activities. And then we'll get to the pulmonary function tests next, because those are helpful, but like more monitoring. I stole this slide from Francesca. Thank you. I spelled your name wrong at the bottom. Sorry. But to my point of like the PFTs are helpful, but they're not telling you ILD, yes, no, right? The PFTs can reflect a lot of things. It can reflect the respiratory muscle weakness. They can have skin thickening that's so bad around their chest that that's causing some extra restriction for their PFTs. Obviously, interstitial lung disease can be contributing to that, but the lungs have other things going on as well. there's a big tie between, as I mentioned, if you have poor esophageal motility, that sometimes like just even laying down at night, the patients, if they say they cough at night or in the morning, they're like, they have this brackish taste in their mouth, they're probably silently aspirating because that is just like this tube with like no motility. So it's coming right back up into their lungs. So that can be also like a circular issue with ILD and GERD. So this is a pulmonary function test. It is not fun. If anyone has done it, it's not fun and not easy. But I beg you, whatever specialty you're in and you have a PFT on someone, and it's helping guide your management, like actually look at the loops, look at the, make sure that it passed the ATS criteria, the green check, yes, that they did it right. Effort was good, et cetera, because sometimes it's just not doing it for the first time, poor effort, whatever, that can kind of make it skewed and very abnormal. So kind of take a look and look at the values yourself and see what they mean. And then these are the main ones that we like to do is the spirometry for the FVC, the plasmography for the TLC. The MIP and MEP are helpful. Sometimes those are a little more challenging to interpret. And then the DLCO. So we really appreciate like getting all of those measures. A lot of times from the outside, they'll be missing some. I'm not going to go over this because it's very small and we only have 15 minutes left, but this is just to illustrate a patient of ours. You can see how bad the FVC is, 39%, TLC 48%, DLCO 54%. So most people knee jerk in a scleroderma patient would be like, oh, that's interstitial lung disease. But actually this patient's CT scan was beautiful. They had overlap with myositis. So this is all muscle weakness. And you can see the trajectory over time that she was doing pretty poorly. And first it's your volumes. And so you're like, oh, the exchange, it should be okay, right? The alveolar space, but it's just like, you're kind of hypoventilating so much that you're not kind of using that exchange as well. So your DLCO is going down. So this patient eventually did get a stem cell transplant, but this is actually more for her myositis that was causing this issue. 6-minute walk test. That's the beauty of this is to have the oxygen probe with them. So we need to make sure it's on their forehead or the ear for the issues that I mentioned. But so the 6-minute walk is okay. It's great to know the distance, but we're actually looking for the desaturation and like that your heart rate is going up too high, things like that, that you might be struggling on your oxygen exchange. So this is the young lady that we showed you, her chest CT. And she kind of at rest had like a little bit of tachycardia, but like once we had her do the 6-minute walk, she was like up to 164, 173. And then her pulse ox, plummeted down to 88% with the 6-minute walk. And so, kind of this was picking up that she was having some significant desaturations with the 6-minute walk test. So this has been very helpful for that. This is on the horizon. We have some collaborators and wrote some grants, not funded yet, but it would be nice to quantify the degree of interstitial lung disease a little bit better and characterize it. There's like different types of the interstitial infiltrate you'll see, like ground glass, different fibrosis, et cetera. So it's just an idea to help quantify that. So we'll get there. Again, I'm flying through a little bit of this just so that you guys get a little taste of the different things. But pulmonary artery hypertension, we have a handful of these patients. I would say like 5% is pretty fair across the different cohorts. But basically this is a more rapid shortness of breath. If the kids all of a sudden like can't get up the stairs and they could just fine, but they're like huffing and puffing. So that it's usually a rapid dyspnea on exertion. And then typically in kids found through echocardiogram, our echocardiograms are pretty reliable. We really only do that right heart cath, which is like the gold standard if the echocardiogram is giving us some clues that something might be right, as well as we'll do some ancillary testing to that too, like an exercise echo EKG, and just see if there's changes that are pushing us towards doing the right heart cath. And then in addition for pulmonary hypertension, just a little kind of pearl is that if your pulmonary function tests like your FVC, your TLCO are wonderful, so your volumes are fine, but your DLCO is going down, sometimes that's pulmonary arterial hypertension because that's the exchange is not happening, right? But your volumes are okay. The other cardiac problem I kind of mentioned was the muscle disease associated with the kids with myositis, U3-RMP, things like that. That inflammation turns to fibrosis and then the electrical current can't make it, so they get arrhythmias. When kids die from scleroderma, it's usually this. So it's rare, but in the cohorts, especially the older, even in the current cohorts, it's usually this. So that's why we're like very much on the kind of lookout for this. We do annual screening, even if it's totally normal for EKG echo, but then if there's symptoms or further or abnormalities, then we'll push to get Holter monitor for several days, exercise stress, EKG echo. And then, as I mentioned, that cardiac MRI for that one patient, we're like, something's wrong, something's not going right. Even though EKG echo, we're like, okay, we knew something was going on. So she got the cardiac MRI. And then this is a recent study from an Italian cohort that shows like the cardiac MRI was helpful for these patients, and actually 2 needed a heart transplant. 1 did not survive, 1 did, but it can be quite severe. And this is a current publication from 2025. And then the GI issues can be everywhere. The main things that we see are the gastroesophageal reflux disease, the dysmotility, and then dysphasias. Like the patients will say, oh, things get stuck in their throat, like up or mid throat, and then they need a lot of like water to swallow, things like that. The main thing we pay attention to is their weight and BMI, as mentioned, and watching their growth curve. This is an example of a patient that has that horrible growth curve that I showed you. And you can even catch this on their CT. Again, just another pearl. Like when you're looking at the CT for interstitial lung disease, also to see if they have that patulous esophagus, that giant dilated esophagus. A lot of them will have it like dilated all the way throughout. And that's just basically showing that they have some major GI issues. These patients should be sleeping with their head of their bed elevated, be on PPIs and H2 blockers, et cetera. So this young lady, unfortunately, her hand's over it, but she has a G-tube and she has like pretty severe joint contractures. Her mom has to like lift her down. She can't even like bend down and get down. It's quite alarming. All right. So these are the initial tests that I usually recommend, is to get esophagram and the gastric emptying study. Those 2 are non-invasive, and they're going to show you at least like some degree of dysfunction in the esophagus and the stomach, which are the main organs initially that are affected in scleroderma for the GI. And then if they're having any of that dysphagia, or they feel like, the food or whatever's coming up, then we can also do a swallow study with speech pathology. More invasive, but pretty important. And when Viva is here, we're doing a lot more where the pH probes and the manometry. The esophagus has like the 10 is the lower esophageal sphincter pressure, like the minimum. A lot of our patients were like below that, and it's just basically no motility of their distal esophagus. It was quite shocking, and the patients have no symptoms. So you scope them, and sometimes they'll have like reflux damage, right? And that can cause Barrett's esophagus down the road. So you do need to pay attention, and PPIs are good for them. Endoscopy, et cetera. There's other testing as well, but I just want to mention the main ones. On the side is just saying that there's a correlation between having GERD and also the esophageal dysmotility and a patulous esophagus with the presence of interstitial lung disease. So there is that correlation both in kids and adults. This was from our lovely residents and now GI fellows, and VIBA. They kind of did a better job at actually looking and seeing the percent frequency of abnormalities if you had the GI testing. In the publications, a lot of it's like, oh, 30% GI affected. But if you actually do the evaluations I mentioned, 75%-ish are affected. And as I said, there are patients that we reviewed their pH probe monitors that had 125 acidic episodes, and like a lot of them were proximal, and some lasting like the greater than 30 minutes. They never hit the button. They never had symptoms. And this is like 18-year-olds. Like these are people that are totally capable of hitting the button if they have a symptom. So just again, I'm just reiterating, because I've had patients come from across the nation at big pediatric academic centers that the GI is like, well, they don't have symptoms, I don't need to check anything. No, that's not the answer. Like we have to investigate. These kids need to protect their GI system. So these are just kind of lessons I've learned working as a team here. And then the most impressive organ system on their quality of life across multiple cohorts is actually the GI system. So paying attention to the GI system and treating that appropriately does actually help the quality of life of patients across different rheumatic diseases like juvenile arthritis, lupus, et cetera. These kiddos had the lowest BMI, and then they also had the highest like GI impact on their quality of life. And then we published more recently with one of my students that this quality of life outcome measure, looking at how much these GI issues bothers kids, is helpful, and it's sensitive to change. So we're hoping to use this like we use in our clinic, but use it more formally in our clinic moving forward. And then other symptoms, we mentioned the scleroderma renal crisis kind of in passing. It doesn't happen that often because the kids have that low antibody positivity. There's some neurologic issues, but they're not central. They're usually peripheral from that tightness from the skin. It's usually like a carpal tunnel. And obviously, we don't have time for this in this lecture, but psychological, emotional impact is huge. Their performance in school, keeping up with their friends, kind of working to get more resources, et cetera, is key. This is a patient of mine drew this, and they feel like scleroderma is a yin and a yang, kind of building on their strengths. There's stormy, cloudy days, but there's sunny days. So, close one door, open one door. That's what they're trying to say. So I thought that was cute. We're not going to go over this because we don't have time. And then don't forget about the generalized symptoms. I love this slide. This is from my colleague, Katie Moore, but she's like, mission, get out of bed. Status close, close enough. Some of the kids, I didn't realize it, honestly, until we had the stem cell transplant kiddos. That was one of the first things they said. They're like, I can wake up at 8 a.m. instead of noon, and I can do 4 things and shop. And I had none of that energy before. And I honestly, because, it's fatigue for physicians when we ask these questions is a little nebulous, but then once I had patients say they could do X, Y, and Z that they could not do before the stem cell, and they volunteered it, I was like, okay, fatigue was a huge part of your disease, and I just didn't realize that. So these are this is just my take home slide, is that, all these things are impacting the kiddos. Hopefully you've kind of taken that away, that these are the main organ systems. These are the things to look out for, like the ILD, the cardiac mortality, the GI issues, the esophageal dysfunction, and the musculoskeletal, and the impact on these kiddos. This is just for later if you guys have access to the slides. These are I wrote these for pediatric rheumatology colleagues across the nation. So general pediatricians totally applicable as well. They're tables that it's how do I look for this organ system and what tests do I do, and et cetera. So hopefully that's a helpful resource for you. And then I was just mentioning the game changer, the ILD study, and some key clinical outcomes there. But that is it. I want to say thank you to my patients and then all my colleagues here that have been part of our Scleroderma Center. I think we're doing awesome stuff here, and we're excited. CAR-T is the next thing we're doing too. So we keep going, pushing that envelope, treat these kids and help them get a better life. That's all I got.